thank you very much everyone for having me to speak today. So keeping on the theme of excess weight but focusing on a different population now, I'm going to discuss about weight management in the context of secure mental health inpatient settings. However, before I want to talk more, I want to introduce you to Ashley. In his late 20s, Ashley started hearing voices. And unfortunately, these escalated and led him to attack his brother with a knife. Ashley was subsequently diagnosed with schizophrenia and detained under the Mental Health Act in a secure mental health inpatient setting. And his symptoms are now very well controlled with antipsychotic medications, but unfortunately his weight has continued to escalate since admission, and he now weighs 4 stone more than when he was first admitted. He's gone on to develop obesity, type 2 diabetes, and this has played into his experience of mental illness. So although we've changed some of the personal details around Ashley, obviously to maintain anonymity, unfortunately, rather than being an unusual case, Ashley's is really very much the norm in secure care, and that's really what was a key driver for me to undertake the programme of work that I'm going to talk a bit more about this morning. So as we've heard and we all already know, unhealthy weight is a major challenge for the wider community at large, but particularly for people who are living with serious mental illness. And by that we generally include schizophrenia, related psychotic disorders, bipolar disorder and personality disorder. And the problem's amplified yet further in the context of secure care. So these are patients who generally have offended or they pose a threat to themselves or other people, so they're held under the Mental Health Act in a secure hospital. So this particular piece of work was undertaken through an NHR clinical lectureship. It's a joint project between Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust and Newcastle University, and was funded by the Academy of Medical Sciences through their starter grant for clinical lecturers. And it's been an 18-month programme which is due to finish in May of next year. So the overall aim of the project has been to identify priority areas for weight management in this setting, and particularly the potential barriers and facilitators, and ultimately to triangulate or bring together the research findings to hopefully inform future interventions. The work's very much been led by a diverse steering group, so that's included people with lived experience of mental illness, a third sector organisation called North East Together, several members of multidisciplinary staff and public health and academia, and that's really helped, I think, to hopefully have all these different viewpoints at the helm as the research has gone through. It's been composed of 4 different stages. So in the first work stream, we disseminate an electronic survey to all staff based in secure care services at CNTW, really to understand a bit more about their views and experiences of weight management in this context. And then the findings from the survey went on to inform an ethnographic approach. So essentially this was me spending time over a 6-month period based on a low secure mental health ward to really understand a bit more about what life is like there. Because without spending time in that setting, it's really quite difficult to understand perhaps some of the undercurrent influences or culture around what actually happens or doesn't happen that might not be necessarily articulated through a survey or other forums. This work went on to inform a range of focus groups. So those were based in CNTW Trust with current service users, former service users and carers, and multidisciplinary staff. Again, to hear a bit more about their views and experiences in depth on this topic. And we complemented that with some semi-structured interviews held at a second NHS trust, so that was Tees, Esk and Wear Valleys, which is further south below CNTW. Essentially to try and tease out what was similar and what was different between some NHS trusts, because we know some issues will be to do with around trust commissioning, for example. So we've got to the point of having collected data from these 3 work streams, and then the next stage is going to be triangulating or drawing together the research findings using, again, a small diverse group involving service users to hear about what they feel comes out of similarities and differences in terms of the research themes, and making sense of the whole, essentially. So, although the work's still underway, there's definitely been a few key findings that have come out loud and clear in terms of themes or messages. So, firstly, in terms of the concept of restrictive practice, which was quite new to me when I came into the field, but came up a lot. So this is the idea that because people are held securely and don't have the choice to leave the setting, because they lose autonomy in that respect, every other opportunity for maximising patient choice should be amplified. So essentially, if a service user wants to eat takeaways daily, become obese, develop type 2 diabetes, provided they have capacity, that is their choice. So lots of staff described how frustrating they found it that they could see patients' physical health deteriorating whilst they're in care, but they really had very little clout to do anything about it. In terms of the hospital catering, as you can imagine, that was generally quite poorly received. This is produced on a cook-chill model, so essentially the food is mass-catered, frozen, and then reheated again at the point that it's delivered. So often patients said it was unappetising, the portions were too small, particularly things like the fresh veg really didn't lend itself well to that cooking model, so really wasn't very tasty, wasn't eaten much. But also, sadly, because patients are generally detained for months or years, they got very bored of the menu because it's on a 4-week rotating cycle. So whereas if you're in an acute hospital might be there for days or weeks, that didn't have such a big impact. When you're living there for years, it really does. In terms of physical activity opportunities and sedentary lifestyle, because people are detained on the ward, those opportunities are really quite limited. So if people don't have leave, which generally builds up as their mental health situation improves, if they don't have any leave, then they can't leave the ward, and those options are quite limited. But even for people who did have leave, sometimes it does seem to be quite a facet of the mental illness process itself that people were quite unmotivated to be physically active, even when some of those opportunities were available, for a range of different reasons. In terms of medication, we know that people starting on particularly antipsychotic medication is often the start of their weight gain journey. And although to a certain extent some of that is unavoidable, we did find that people weren't really having those conversations at an early point in time about what the likely weight trajectory would be, and what potentially they could do about that at an earlier stage. Understaffing came up as an issue that you'll probably also be all aware of. Regionally, nationally, mental health services are quite understaffed, and that didn't help in terms of having time for health-promoting conversations or facilitating exercise opportunities. Patient motivation, as I've alluded to, quite often attributable to some of the negative symptoms of schizophrenia, but also sadly because sometimes people had lifetimes of no one really investing in their own care, that they really couldn't see why, therefore, they should be taking the time to optimise their activity and healthy eating approaches because they weren't used to taking care of themselves in that way. And perhaps all of these reflective factors indicate the overall culture. And we know that in the wider community, food can often be used as a bit of a crutch when things are emotionally demanding or challenging, and this was really amplified in the environment of serious mental illness. So I haven't got a huge amount of time, so I'll rattle through the next bits. But in terms of the next steps, our aim will be hopefully to integrate these empirical findings with a review of existing research, and where there have been pockets of previous successful initiatives to build upon that, hopefully with the aim of co-developing a future intervention for implementation and evaluation, and that will be targeted in adult secure care settings with patients and staff, because we very much see them as an integral part of that approach. Some personal reflections on the work. For me, it's been great to work at the interface between public health service work and academia, and I think building on that as a kind of a model for working is quite positive. It's given me great experience of leading an NHS research study as chief investigator, so navigating NHS research ethics, working with management, but also the clinical facing teams. It's given me some small insights as to what it's like to live in a secure mental health setting, and as I mentioned, I think that's really important for presenting recommendations that are actually realistic and might be implementable in practice. Hopefully I've gone some way to building positive working relationships and some insightful findings. However, I have really found it quite challenging to work in this environment, to be a critical friend and perhaps note out areas there where things could change in future, whilst at the same time trying to maintain positive relationships with staff who are working really, really hard and really under pressure in those environments. And learning from that, I think a key learning point from me is that all stakeholders absolutely have to be engaged, motivated, support and involved. Otherwise, initiatives won't be successful in future. So I'd just like to acknowledge my collaborators, the funders of the research,